everyone. My name is Ronen Shechter, and I'm an assistant professor at Johns Hopkins in Baltimore, Maryland. And I'm excited to share with you today our personalized perioperative pain program. I have no disclosures. So in the late 1990s, healthcare providers began to prescribe opioids, pain relievers at greater rates. This led to excessive diversion, misuse, and increase of opioids overdose deaths. In 2015, more than 33,000 Americans died as a result of an opioid overdose, including prescription opioids, heroin, and synthetic opioid fentanyl. In the next years, it kept increasing, and opioid-related overdose death was more than 42,000 and 47,000 in 2016 and 2017, respectively. Now, if we focus on prescriptions opioid overdose deaths, between 1999 and 2015, more than 568,000 overdose deaths occurred, and out of that, 183 were related to prescriptions opioids, which doctors prescribe to the patients. CDC estimated that in 2015, 12.5 million people misused prescriptions of opioids, and among heroin users, 75% reported to misuse prescription opioid before using heroin. Between 2015 and 16, prescription opioid overdose deaths has increased in all sizes of urban areas. The economic burden from opioid abuse is tremendous. It was estimated to be more than $500 billion in 2015, $430 billion in estimated costs associated with fatal opioid overdoses, and $72 billion in costs associated with non-fatal abuse because of increased healthcare costs, criminal justice, and reduction in productive employment. In a study by Dr. Bertram, which was published in Lancet, daily opioids and analgesic doses per million inhabitants was calculated worldwide. They compared between 2000 and 2003 to the years of 2011 and 2013. A substantial increase, as you can see in the graph, occurred in North America, Western and Central Europe, and Oceania. Use of opioid analgesics has increased but remained low in Africa, Asia, Central America, the Caribbean, South America, and Eastern Pacific. The growing amount of attention is rightly being paid to the widespread practice of prescribing opioids for post-surgical analgesia. In 2012, almost 10% of all opioid prescriptions were written by surgeons, and in Australia, surgeons are responsible for more than 6% of patient-initiated anti-opioid therapy. A systematic review by Bickett et al., which was published in JAMA Surgery, found that in some surgeries, more than 90% of patients reported unused opioid analgesic after surgery, meaning they have stocks of opioids left. Besides the quantity of prescribed opioids, length of supply also matters. CDC found that transition from acute to long-term therapy can happen quickly. The graphs that you see here represent sample of opioid-naive, cancer-free adults who received a prescription for opioid pain relievers. The chances of chronic use begin to increase after the third day supply and rise rapidly thereafter. This supports the CDC recommendations that treatment of acute pain with opioids should be for the shortest durations possible in order to mitigate the chances of unintentional chronic use. Surgery is also associated with increased risk of long-term opioid use, a phenomenon known as persistent post-operative opioid use, or PPOU, and various definitions can be found in the literature. Per the American Society for Enhanced Recovery, the incidence of PPOU is from 6% for all surgical opioid naive patients up to 35 to 75% for surgical patients who use opioids before surgery, and for patients with history of depression, substance abuse, and preoperative painful conditions. So in 2017 is when we all got alarmed by the opioid crisis that has swept up on us. As a result, in 2017, Health and Human Services declared a public health emergency and announced a 5-point strategy to combat the opioid crisis to empower local communities on the front line, and its priority goal was reducing opioid morbidity and mortality through better addiction prevention, treatment and recovery services, better data collection, better pain management, better targeting of overdose reversing drugs, and better research. On September 17, 2018, the US Senate passed the Opioid Crisis Response Act that authorized a budget totaling an estimate of $7.9 billion to support fighting the opioid crisis. From all the things we learned until now, we assume that focusing on pain control and opioid prescribing perioperatively should be helpful to combat opioid-related harm, and this can be achieved by identifying high-risk patients and mitigating risks by reducing perioperative opioid use and by minimizing excess prescribing opioids. Now, as an academic institution, we had an opportunity to design an innovative program and change how opioids are managed perioperative. Until today, it's managed by surgeons who send patients home on opioids. Our team recognized an opportunity to provide more comprehensive care for opioid-tolerant surgical patients. By weaning opioids before surgery, by tailoring the anesthetic plan, and by following up after hospital discharge. Building an interdisciplinary team composed of clinicians who specialize in acute and chronic pain, psychiatry, addiction medicine, allowed for personalized treatment plan and address high-risk comorbidities. And before launching the program, strategic planning, including the interdisciplinary team, surgeons, and administrators. In June 2017, the Johns Hopkins Perioperative Pain Program officially launched. Referrals to the clinic are usually made from the patient's surgeon, primary care physician, psychiatrist, pain providers, and anesthesiologists. Criteria for consultations are chronic opioids, history of opioid use disorder, patients on medications, assisted treatment such as methadone and buprenorphine, and opioid-naive patients at high risk to develop PPOU. Through history, physical exam, and chart review, we learn about patients' opioid use, chronicity of pain, age of pain, anticipated surgical pain burden, and coexisting medical and psychiatric conditions. We calculate the milligram morphine equivalent, and patients fill up surveys, which help us further learn about their pain, function, sleep, and coping skills. A considerable portion of the initial consultation is spent on setting realistic patients' expectations, educating about multimodal analgesia, and providing reassurances that the multidisciplinary team will follow the pain throughout the perioperative time period. We initiate an opioid weaning protocol and multimodal analgesia, and we communicate the plan with the primary surgical team, the anesthesiologist, and the acute pain service. Looking at the first 9 months outcome, we found a significant decrease in the morphine use at 3-4 months after surgery relative to the time of surgery, which is at 0-2 weeks. Patients who had their first visit before surgery showed also substantial decrease in opioid use, approximately 50%. The decrease in morphine use coincided with a significant decrease in visual analog scale pain rating starting at 1 to 2 months postoperative, with a significant improvement in physical function as measured by the SF-12 health survey at 2-3 months, and with significant decrease in pain interference score at 2-3 months postoperative. This data showed that our team weans patients from opioids before surgery in patients on chronic opioids and along the postoperative phase while improving function and pain control. Looking also at length of stay, for all Johns Hopkins surgical patients in 2018, it was 6.5 days, and specifically for spine surgery, 6 days. For patients who participated in the program, it was only 5.8 days and 5.2 days, respectively. The tools that we use are multimodal analgesic regimen, multidisciplinary team, and last but absolutely not the least, patient motivation. Systemic pharmacologic modalities involve non-opioids such as acetaminophen, non-steroidal anti-inflammatory drugs, NMDA receptor antagonists like ketamine, anticonvulsants, alpha-2 agonists and local anesthetic, sometimes topical, sometimes through the IV, and sometimes by block. Using chronic pain interventions can also be very helpful, as we are managing pain in the acute and subacute phase. In cases when patients cannot wean off opioids, we transfer their care to chronic pain clinic or back to their provider who managed it prior to surgery. We are very fortunate to have a psychiatrist on our team. Besides pharmacologic treatments use of cognitive behavioral therapy, mindfulness, relaxation, group and family therapy can be very helpful. Unfortunately, increasing number of patients that we see in the acute phase suffer from polysubstance use disorder. Most of them are admitted through ED after a trauma or due to an infection. Our team collaborates with addiction medicine to manage this challenging patient population perioperative. If the patients are motivated, there's success in weaning down opioids increases. And we use various motivational techniques in order to improve it. We try to move the chronic pain patients from expected to fixed and have their pain eliminated for good to being interested in living with less pain and willing to learn and explore new ways to cope with pain based on what they can do for themselves. In 2018, the Health and Human Services reported that from 2017 till 2018, there was a decline in drug overdose deaths in the United States, and that the number of substance abuse facilities and patients receiving medication-assisted treatment have increased. In contrary to 2016, where there was an increase in prescription opioid overdose deaths in all sizes of urban areas, 2018, compared to the year before, there was a decrease. So it seems like we have a happy ending. Well,
thank you.
If we look
Thank you.
around 2017, we can see a decrease in overdose deaths from prescription opioids. However, total opioid overdose deaths is increasing in an alarming pace, mostly from not prescribed opioids or street opioids like the fentanyl. In 2020, close to 69,000. 69,000 Americans died as a result of opioid, and this is 20,000 more deaths compared to 2017, when it was just 7,000, which is also a very high number. So one possible explanation for this drastic increase in opioid overdose deaths is likely to be the COVID-19 pandemic. Substance use disorder patients are increased risk to both contract the virus and to overdose. The increase in overdose deaths in relapse is likely multifactorial. First, obtaining medications such as naloxone, buprenorphine, and methadone may be more challenging. Second, social distancing increases the risk to overdose with no observer to deliver naloxone. And third, due to the limited support and increased stress, this patient population may turn to substances for support and relapse. Telehealth, which allows real-time audio-video communication between patients and clinicians in remote locations, was available prior to COVID-19 and became our main tool to continue managing perioperative pain and weaning opioids from new and established patients. Our experience taught us that telemedicine is convenient for surgical patients, decreases costs, and reduces missed visits. On the other hand, it alters the traditional patient-provider relationship and prone to technology failure and to inequality in access or your ability to use technology. Even though the COVID-19 pandemic, our clinic continued to grow and almost doubled the number of visits in 2021. So what we have learned since the clinic has launched. First, we learned the interventions have been successful in preventing escalation of prescription opioids overdose deaths, though it is still there and we have much more work to do. Second, focusing on substance use disorder patient population is the key to slow down and possibly reverse the trend in opioids-related overdose deaths. And last is the perioperative period is a window of opportunity to catch them, as it is more likely for polysubstance use disorder patients to be more motivated to make changes and recover from their addiction. That's it, and thank you for listening. And if you're interested to learn more and build a perioperative pain program, you're more than welcome to contact the email that I